of the Men Division and the Ed Schteingart Lecture Committee, I welcome you all here today. I particularly want to welcome Monica, Ed's wife, and his kids, both Dan and Miriam. Welcome again. It's great to see you. So I get to say a couple of words about my relationship with Ed and his relationship to our division and the university, and then we'll have an introduction by my colleague Bill Rainey for our esteemed lecturer today. So Ed came to the University of Michigan in 1959. And what I show you here is a picture of Ed with some of his colleagues in 1970. Two of these giants are in the room today, and it's your job to make them out before the end of the In the front row is Jerry Kahn in the middle, one of our giants in the adrenal field. Now, working with Jerome Kahn was the beginning of what probably seemed like a rather lofty goal to Ed. Well, not to Ed, it didn't seem lofty, to everyone else, to create the world's best, albeit first, multidisciplinary adrenal cancer program. In a final analysis, not only did Ed do just that, but he really helped create the very concept of a multidisciplinary clinic, where doctors saw patients together at the same time and in the same room even, to create a unified diagnostic and treatment plan for each patient. Moreover, Ed's work really was the foreshadowing of translational research in personalized medicine, as we define it today. And in his later years, Ed actually became a leader in the education of our junior faculty in the field of clinical research, and he served as the director of the university's training program in clinical research and was the president of the National Organization of Directors of this group. So with all that said, I think for me, the most notable characteristic of Ed Schteingart was his humility. Ed was Millie Schembechler's physician and developed a unique relationship with Bo, Millie, and their boys. Millie, as you know, died of adrenal cancer. Ed was the solitary catalyst for the formation of our adrenal team here at Michigan and our endocrinology program in the Cancer Center. Ed's establishment and sponsorship of the first International Adrenal Cancer Symposium that brought together the world's adrenal researchers and clinicians for the first time has been the singular most important development for the facilitation for international collaboration. And just today, literally today, our team here at Michigan has formally and legally launched the fruits of Ed's labor, the A5, the American Australian Asian Adrenal Alliance, today. And this A5, which will facilitate collaborative research, will be leveraged to gather support from the government and industry to advance research and care in adrenal disease. It's a big deal. And in closing, I'm grateful for my comments. I'm grateful to Ed for his leadership, his mentorship, his altruism, and his friendship. And I welcome everyone here on this special day. Please stick around at the end for our reception. And I now ask my friend and colleague Bill Rainey, the first Jerome Kahn professor, to introduce our speaker today.
Well, it's a great pleasure to welcome all of you here today to hear sort of a jewel of the adrenal research field, Celso Gomez-Sanchez. And rather than, it was a little hard for me to memorize his flow sheet for training, but I've got it up here and I call it the 8 flags over Celso. And it sort of starts with his clinical training, his medical school training, which occurred in his home country of Peru. From there, he came and did his internist training both at Mount Sinai in Ohio, and then moved very close to us to the Henry Ford, where he did his internship in medicine. It was at UT Southwestern, where he moved to do his endocrinology subspecialist training, that he met and fell in love with adrenal research. There was a group of researchers there studying endocrine hypertension. He was mentored by a man named Norman Kaplan. But there were a whole series of people doing steroidogenesis research in several departments at that school at the time that had a huge impact on Celso and his research drive. From there, he moved to Florida, then to Missouri, and he's held a number of positions in endocrinology divisions, from professorships to directorship of division. He has lit and seems to be staying still now because he's been in Jackson at the University of Mississippi for 15 years, where he and his partner for many years, at least Gomez Sanchez, has ran an internationally known adrenal research team in Jackson. Now, I want to say just a few things about why many of us believe that Celso Gomez Sanchez is a treasure to the adrenal research community, particularly those of us that study aldosterone. And first, I want to say that he is the quintessential scientist clinician, and I purposefully reverse those. And I think of Celso rounding in some kind of jacket like this. It's probably not true, but it's my vision of how Celso would round with his stethoscope in his pocket, carrying a pipette, gel pictures, and perhaps a few other lab bench research materials with him. But he is known to be the man who creates the most fascinating tools for the whole community and gives them out without hesitation. One example is an enzyme many of us have studied, which is 11-beta hydroxylase. It's an adrenal enzyme. There's an aldosterone synthase that 96 to 97% similar that we had all tried to make antibodies for years. It takes people like Celso that just say, I'm not giving up, to actually achieve these goals. He's done this for these antibodies and given the reagents to everybody, but he's done it for lentiviral constructs. He's done it for antibodies to steroid hormones. He synthesized his own steroids. He's comfortable at the bench. Second, everybody's got one of these. I'm sure when you go to a meeting and there's somebody who gets up and starts saying, you know, your research is fascinating. It really builds on what was done 54 years ago by such and such. Celso's that person. So you see him get up. You worry he's going to ask you a question about research from the 70s or 60s. Usually, though, he's just informing you that you might want to consider reading a paper from that time. Finally, he's the guy, he's the devil's advocate to whatever you are thinking right now. So he's the person at the meeting that if you're getting up and you're telling everybody how to do clinical practice for this disease, primary aldosteronism, and saying, well, first you've got to do this, and then you've got to refer them to a major referral center. He's the person that's going to say, how practical is it to develop the guidelines that requires everybody with primary aldo to go to a major referral center? That's probably why you're not on the new guidelines author list this time. He was on the first one. But he is the guy that's going to stand up to authority and ask questions that others should be asking. Maybe it's because he just doesn't have any fear or anything to lose. So with that, I'm going to stop, and I'm going to welcome you to a contrarian's approach to primary aldosteronism. And if it gets too far into the weeds, one of us will try to reel it back down to earth. But thanks so much for coming, Celso, and being here today.
Now then, if we can just find your talk.
It's this one, I think.
Excellent.
Yeah, and then
Play.
perfect. It is indeed an honor to be here. I met Eduardo many, many years ago in Endocrine Society, various Endocrine Society meetings over the last 45 years. I have been going to the Endocrine Society every few years. And the last time I saw him was in Miami. Before I started going routinely to a meeting, a Spanish meeting in Miami, in which Latin American physicians come for training in an intense course in endocrinology and diabetes. He was the adrenal guy. I sort of inherited that, but one year we overlapped. I forget exactly how many years it was. It must be 7, 8, 9 years ago. I exactly don't remember. And we had a great talk. And he gave a talk on something very unusual, which was hyperplastic adrenals, not congenital adrenal hyperplasia, but hyperplastic adrenals, which I have never heard anybody talking specifically about hyperplastic adrenals, which covers a very large field. So it's indeed an honor to be here. Well, let me see how I handle Macintosh. Okay, I want to say a few historical features, and then I will say in a few minutes what we teach fellows about primary aldosteronism, and then let's look at the subtleties and controversies in this particular area. It's one of those. The two greats in endocrinology and stereobiochemistry is Edward Kendall from Mayo Clinic and Tadeusz Reinstein. Tadeusz Reinstein is one of my heroes. At age 90, he wrote a 100-page paper on the mushrooms of central Switzerland, which is a remarkable thing at that particular age. And both of them isolated basically cortisone in different areas of the world. And both of them were involved in the isolation or a substance that was called the amorphous fraction. In the historical stage in adrenal studies, you isolated the steroids by doing different extractions with different solvents, and then you crystallize them. And then you characterize it both biologically and chemically, and that's how you get chemical structures. But there was a fraction that refused to crystallize, and it was called the amorphous fraction. And there was people that believed in it, and people believed that was an artifact. But anyhow, Sylvia Simpson and Tate, I'm told that she was better than him. I met them both. And James Tate were the discoverers of aldosterone, but they didn't do them by themselves. They did it with a team, and the team was a master chemist was Tadeusz Reinstein, and then the Ciba pharmaceutical industry that provided the muscle, that is provided the 500 kilos of bovine adrenals where they did the extraction, and they were able to obtain approximately 10 milligrams of aldosterone. You can imagine how much work that would be. And it was Tadeusz Reinstein that was able to elucidate the structure. And because he had an aldehyde in position 18, he called it electrocortin. Initially called electrocortin because of the effects on sodium retention, but because of the aldehyde, he changed the name to aldosterone. And then the honor follows down here in Michigan with Dr. Jerome Kahn, that was able to see what everybody had been looking, but few had been seeing. He was able to connect the dots, and that's the important thing. He connected the dots. He had a patient that all the characteristics of primary aldo, and he assumed that they had to be secreting excessive amount of aldosterone. And he had the insight, and I call it the guts, of going and sending him to surgery and looking at the adrenal and finding that tumor. Others had actually found similar cases, like this one from the Harper Hospital in your neighbor Detroit, but they did not connect the dots. So, as I say, they joined those that are forgotten by history, because there was many cases like this. And the glory has to go those with educated minds that led to discoveries. Connecting the dots, and is a great honor, obviously, and they should get the glory, those that put things together and really advance the field, and that was Dr. Cohn down here in Michigan. So let me say first, is primary aldosterone a benign disorder? This is one of many studies that this come from France, in which the cardiovascular events are increased 2 to 3-fold over patients, similar patients with similar characteristics with essential hypertension. So it's not a benign disorder. In the Cohn register in Germany, you can find that after 14 years, the probability of survival is significantly less in patients with primary aldosteronism than the patients with hypertension or normotensin control. So it is not a benign disorder. It's a disorder that should be looked upon and should be treated appropriately. And it's very, very important, although it is highly neglected, especially in our country, which is very unfortunate. Well, the incidence of primary aldosteronism, when Dr. Cohn studied, he said it was about 20% in 1965. But this was a referral center. 65, aldosterone was very, very difficult to measure, so obviously all the suspected patients were funneled down at University of Michigan. And then, for example, Larry Fishman in Vanderbilt with Graham Little start studying patients, and the incidence started decreasing in different groups like Cleveland Clinic or in Belgium, because they were screening only with patients that have clear-cut hypokalemia. If you had any reason that might produce hypokalemia, they were not studied, and therefore they found incidence was very low. Brian Holland and I in Dallas in the 1970s, we studied a bunch of unselected patients. The only condition was that they could come to the hospital, to the CRC for 21 days. Not very many people can do that. And we did very complicated studies. And we, much to our surprise, we found incidence 7%. Then later on, again, looking at what everybody's, seeing what everybody looks, Hiramatsu took the data that everybody had seen, the plasma renin activity and the ALDO, and he expressed the ratio and found that was a good screening technique. And that led to Dick Gordon in Brisbane to put an advertisement in the Brisbane newspaper for a drug study. And they studied all, and he found 9%. And since then, 9% had primary ALDO. And since then, there's more than 50 studies in the literature that have found an incidence somewhere between 2 to 16%. But as your blood pressure gets worse, the incidence increases. And as David Calhoun at UAB has shown, if you have refractory hypertension, about 20% of patients have primary ALDO. And if you have obstructive sleep apnea, up to 20% of patients have hypertension. This has been reproduced in Poland and several other countries, somewhere 18 to 22%, so 20% is a good value. Okay, so it is really common disorder. Now, how common is in primary care? I remember seeing a patient in endocrine practice that in America the incidence is maybe 1% or a little less than 1%. And probably the best study was done by Pablo Mulatero in Torino, in which in patients from primary care clinics, the incidence was 1% in Italy, about 2% in Germany. But what he observed is that only 7 or 8% of patients were studied. So 93% of patients were never studied. And of course, you never study somebody, you never find anything. So he went and convinced a series of primary care physicians around the Torino area to just send patients for them to study, unselected patients. And they sent 569 newly diagnosed or 1,000 patients that were already diagnosed. And overall, he found an incidence of 5.9%. So it's a common disorder, seldom diagnosed, but it's a common disorder. Now, it's a syndrome that's due to the excessive autonomous production of aldosterone causing hypertension, cardiovascular damage, and hypokalemia in the more severe cases. Most patients are normokalemic, the usual way that we study them. Now, the criteria for diagnosis, and I'm not going to go into the details, is suppressed plasma renin activity because angiotensin II coming from renin, basically through a cascade of the renin-angiotensin system, is a primary stimulator of aldosterone secretion. So you have inappropriate secretion of aldosterone is going to suppress renin. So if you have these two things, it's a way to diagnose, and you use a variety of techniques to do that. But if we say 5.6% of the hypertensive population, and nowadays it will be worse. With the new guidelines, we think that maybe there's almost 50 million Americans have hypertension, so it's impossible to study everybody. So we have to be a little selective. So if you have hypertension as severe or resistant hypertension, hypokalemia, or you have an incidentaloma, or you have a family history of early onset hypertension, or if you have a CVA, cerebrovascular event at a young age, or a hypertensive first degree relative of patients with APA, you enhance the population, and therefore those are the ones that preferentially be studied. And then you do the screening test, aldorenin, and then if it's obvious, you know, when things hit you in the eye, obviously you don't have to do fancy things because they are so obvious. Then you diagnose it basically, or you have to use a confirmatory test. And all of them are based in giving excessive amount of salt to suppress the ALDO. And I'm not going to go through all of them. So basically when you do the aldorenin ratio, if the ratio is elevated, and this is what we use and many people use, but it can vary a little bit in different institutions. If it's greater than 30 and the ALDO is clearly high, the likelihood is extremely high. If it's much higher than that, it's almost never wrong. But if it's intermediate, it's possibly, and it's low, it's very unlikely. But we have a few cases with normal aldosterone. If you use plasma protein concentration, you have to look at what method they have used, and that can change with respect to the ratios. Well, at the very beginning, when Dr. Cohn saw the patients, he saw the most severe patients. So most of them had aldosterone-produced adenomas. Then it was described that many patients actually have hyperplasia, but they tend to be less severe. So the incidence of adenomas is between 30 to 7%. The hyperplasia is between 30 and 7%. So there's a lot of overlap according to who studied them. And then rare cases of hyperplasia, carcinomas are very rare. I have seen only 2 carcinomas in the last 45 years, so it's not common at all. And extra-adrenal aldosterone-producing tumors in the ovaries are extremely rare. I know of only 2 described cases in the literature. Maybe there's more. And there's some familiar cases in which type 1 is a glucocorticosuppressible, in which there's an extra chimeric gene that has the promoted region of the 11-beta hydroxylase and the coding region of the aldosynthetase, and this new gene is expressed in the zona fasciculata and regulated by ACTH. Type 2 is a basket case. A few families, there's linkage to this particular chromosome, but there's no mutations in that region of the chromosomes. Type 3 due to a potassium channel mutation called KCNJ5. And type 4 is the newest one. Few cases described of a T-type calcium channel, which is called CAC-A1H. Yeah. So once you have diagnosed it, you can have an adenoma, which is using one side, or you can have hyperplasia in both sides. So you're going to use what's called adrenal vein catheterization, which basically involves putting a catheter in the drainage, in the vein that's draining each one of the adrenal. The left one looks very complicated, but apparently, according to the radiologist, it's very, very easy to get in. And they are successful in 98, 99% of the cases. The right is complicated because the vein can come laterally, posteriorly. There can be hepatic veins, lumbar veins down there. So it requires some degree of experience. And part of the problem with respect to controversy comes from this, the protocols. The gurus tend to do bilateral simultaneous, in which they put the catheter at the same time in both sides and they collect samples at the same time. Most places, at least in this country and many other countries, they do that sequential. They put in one side and they put in that side. And some of them, especially in Japan, they tend to have very, very thin catheters. They go inside the adrenal and they drain the top, the middle, and the bottom of the adrenal. They have really segmental drainage in which they measure the aldo. First of all, you have to measure that steroids are coming from wherever you are actually collecting. And that's what you call the selectivity index, which is the comparison of what comes from the adrenal and the periphery. Obviously, it has to be hard. Everything has to come from the adrenal. And then the other thing is that not only you collect that, but there's different ways of collecting. Again, some groups do absolutely no stimulation. They believe they should be done in the basal conditions. And I will discuss some of this controversy in a second. Or you can give ACTH, either bolus or ACTH infusion. There's advantage and disadvantage of each one, but for practical purposes, these two are kissing cousins, I call them. You know, it's very similar. Now, one of the problems came out now from a study that I participated called the PESO study, which is an outcome study. It was primarily organized by Tracy Williams and Martin Renke from the University of Munich, in which one of the problems with respect to outcomes is that everybody, every group had different criteria for outcomes. So I participated in the group designing this, and it was trying to decide a consensus on the criteria. Why do you consider a complete success, a partial success, or no success? You'll be surprised the differences. So I used the Delphi technique, in which you send a series of questionnaires. You send the first questionnaire, and there's a certain degree of agreement and disagreement. Then you take the disagreements, and then you take a second questionnaire to try to narrow the differences between the different groups until finally, after the fourth or fifth questionnaire, you get an agreement. And after that, 12 groups and all the data that was analyzed, and you see the tremendous difference in clinical success. Complete success is after you do an adrenalectomy of the affected side, the patient was cured. Normal blood pressure, required no medications. Partial success was either the blood pressure was decreased with the same amount of medications, or the blood pressure was decreased with decreased number of medications. And absent success, nothing happened. Okay? But then we also did the biochemical outcomes. The biochemical outcomes was considerably better. And that meant that the hypokalemia was corrected, or the aldorenin ratio was normalized. You see, completely corrected. As you can see, there's a wide variations in success rate, especially clinical success rate. And that's one of the things I want to consider. One of the problems is the group of my friend of Gianpaolo Rossi is very dogmatic about how it should be done. It should be done simultaneously, and at the same time it should be done very quickly, simultaneously, and no stimulation whatsoever. And he criticizes anybody that does the opposite. And he did a study in which he put both simultaneously and did collection at 0 and 15 minutes, and then compared the 0 from one side with the 15 minutes on the other side, and he found discrepancies. And he said, although it didn't affect the lateralization in his study, but it could potentially affect lateralization. Then André Lacroix in Montreal did a similar study doing sequential versus simultaneous. And he said it really makes no difference. But the caveat is, when you do sequential, you have to go from one adrenal to the other one within 5 minutes. At least in our institution, the poor radiologist can take 20, 30 minutes. So obviously they cannot do it in 5 minutes. Maybe they have a super radiologist that can do that. And the other problem is a human nature. Our radiologists like to go to the easy side first, and then the difficult side next. And of course it takes a lot longer time. That you went to the difficult one first, and then went to the easy one second. So the time frame will be completely reduced. But they like at least to have initial success and encourage them to be able to do it. So that can create problems. And this is one case published, and we have had cases like this from the laboratory of André Lacroix. And if you look down here, in the before administration of ACTH, you see there's really no difference between the left and the right adrenal. After ACTH was given, this goes to 585,000, and this 32,000, so grossly lateralizes to the left. And you see a ratio of about 64 after ACTH. Well, they took that adrenal out, a 5 millimeter in the left adrenal. What happened clinically? Nothing. The patient was exactly the same as before that. So it was a failure. And the second case that they had, in the basal, there was lateralization. You see significantly greater in the left adrenal and the right adrenal, but there was absolutely no lateralization after administering ACTH. And wisely, they decided not to take the adrenal out because they interpret this that the aldo was coming from both sides. But if you have gone through this, you might have taken that. Of course, you have to speculate because it's the only way of doing it, that you might have missed completely the case. And as you can see, and they found that in 28% of cases, there was conflicting lateralization. Gianpaolo Rossi also finds about 20% conflicting lateralization, but he believes his data of basal. And he thinks that the other one is simply complicating things, but I don't think so. I think that Andre is correct in which they can be. And that will lead me to later on to describe my thesis of what's going to happen. One of the studies done by the Munich group is doing a quantitative type of MRI of the adrenals in which they calculate the volume. And if you can see both in the left and the right, and just look at the left, where the adrenal is affected with an adenoma, you can see that the size of the opposite adrenal is slightly higher than normal, suggesting that that is also abnormal. So that's one aspect of that. Second, what did I do? What did I do? Okay.
Just go back to your.
Okay. Go back to where? No, that's not yours.
Oh, that's mine. Sorry. We get to introduce you again. Let's see where yours go.
In the back?
Maybe.
No.
All right.
Sorry. I thought I didn't do anything.
We'll go with this one. And we'll take you down. Right down there.
Yeah.
Is that close?
Yes. No, the previous one. Oh. Okay. And this is a study that was done in Australia, in Brisbane, in which basically they diagnosed the patients, and before doing a fluorocortisol suppression test, and you can see it's abnormal, they did adrenal vein catheterization, they removed the affected adrenal, and they found that people improve or cure. And then they repeated that 6 months later, and you see the patients that were improved did not suppress normally. And if you look at the renin increased to the normal range, but it was not to the same level as the patients that were cured, suggesting that about 30% of the studies were not completely cured, and they did not really have unilateral abnormality, but the abnormality was bilateral. And we have shown, before 1978 from a study that we did with David Kemp. David Kemp was one of the students of Dr. Kahn down here in the 60s. And patients with adenoma are very, very sensitive to the administration of tiny doses of ACTH. These were milli international units infusion. So tiny, tiny, tiny infusion. They are very, very sensitive. Well, the field advanced tremendously with the discovery by Rick Lifton from Yale University of mutations of channels and pumps. And he described mutations like KCNJ5, which is the potassium channel. And then a series of other pumps and channels have been described. And this is a description that's a few years old, and I didn't want to put Bale's data, which is more recent and not published, but he can tell you later on about it, in which basically if you are from an Eastern Asian, both China, Japan, KCNJ5 mutations are very common, whereas in Eastern Europeans, they are significantly less common, and there's other mutations that are a little bit more common. And there's a significant number of patients that have no mutations, and something that work that Bill is doing that is going to challenge that view very, very nicely. Well, there is a comparison of genotype versus phenotype with respect to these somatic mutations. Adenomas with KCNJ mutation overall tend to have bigger adrenals. And they tend to be more women than men with those adrenals, and they tend to be younger. Okay. And there's a controversy with respect to the cell characteristics. There's one group that is very, very strong. They have strong opinions about everything, but they're very, very strong in this, that KCNJ5 mutations mostly have fasciculata cell characteristics with clear cells, with very heavy with lipid droplets, where other mutations tend to have more compact cells like zona glomerulosa. However, other groups, especially the group from Holland, for example, suggest that it's not as clear as that. And many of the KCNJ5, yes, you see a lot of clear cell, but also you see within the same tumor areas that have compact cells. So it's not as clear as that. And in my opinion, they are correct. It's not as clean as that over there, more clear cells than KCNJ5. So we embarked in a trip to try to get specific antibodies. As Bill said, people have tried for many, many years, have not succeeded. And it was tour de force. Every area that you see yellow and green, we created monoclonal antibodies. Every single area. Okay. And then we evaluated by ELISA and then Western blot. And more than 500 Western blots. I don't remember exactly how many, but clear more by 500, probably closer to 1,000. We only found that 2 antibodies for the B1 in this particular area of the molecule and 2 antibodies for the B2 in that, out of those close to 1,000 that we screened. And then we obviously use for doing Western blot and immunohistochemistry. And in normal individuals, there was 2 different patterns that emerge. If you are young, then the distribution of the aldosynthetase of B1 tends to be throughout the zona glomerulosa, just like if you are a rat, basically. Throughout the zona glomerulosa in a more or less continuous way. Okay, not every cell is labeled, but it's throughout continuous. As you grow older, that continuous disappears, and then you have clusters of cells that have been called various names. And probably right now, the most common name, although some of my long-term collaborators don't like that name, and I don't have a dog in that fight, they call it aldosterone-producing cell clusters, or APCCs. Okay, and these tend to occur, and Bill has shown that the number of these APCCs increase with age. They are very few when you are young. They are very common when you are old. Then we start using these antibodies to do a series of tumors that were sent to me by Gianpaolo Rossi and Francesca Giocco. Giocco means clown, but she was a really nice, very serious girl. Came to my lab for 6 months, and she did all these stainings. And we did double staining. So whatever you see in green is the 11-beta hydroxylase. What you see in brown is the aldosynthetase. As you can see, this particular tumor is fairly uniform, and the green and the brown are clearly separated. And I will show you, this one has a lot of more areas with green and a lot of areas with brown. And I'm just showing these nice areas with green down there within an ocean of brown. But then as you see that this one, the greens are by far, so cells expressing the 11-beta hydroxy are by far more common within that tumor. And all these tumors had mutations of a KCNJ5. So you can see there's tremendous variation in this. Furthermore, these that have a KCNJ5 mutation, we didn't find any staining within the tumor of the aldosynthetase. It was in some APCCs outside the tumor itself. It lateralized, it was treated, and according to Gianpaolo Rossi, the patient was cured. You know, and I'm just showing this one even have less areas whatsoever. And so I'm just showing different areas down here so you can see the pattern. Then we have this patient that had a very large adenoma down here that you can see, and again only APCCs. And then we have a few that we couldn't find any staining for CYP11B2 aldosynthetase. So there was two explanations, a plausible and a less plausible, or nearly impossible maybe. Well, the plausible is we just missed it. That's the most plausible explanation because the pathology gives you only a piece of the adrenal, and we just missed an area that had the aldosynthetase. That's a plausible explanation. The less plausible is, can these cells down here be producing aldo by alternative mechanism? A possibility, a very less likely possibility, but I wouldn't rule it out because animals in general divide into 2 big groups. There's a group like human and primates, the rat and mouse, the guinea pig, that have 2 enzymes, one in the zona glomerulosa and the one in the zona fasciculata. One form aldo, the other wasn't. And then you have cows, pigs, dogs, horses, cats. They have only one enzyme. And they form aldo in the zona glomerulosa, and they form cortisol in the zona fasciculata. And they don't form aldo in the zona fasciculata. We don't have the foggiest idea how that happened, but it is possible that an 11-beta hydroxylase might be able to form aldo, but at yet unknown mechanism, because that's the way it's doing in cows. We are not very similar to cows, but maybe. And then there is a group of patients that have hyperplasia, unilateral hyperplasia. That is, whenever you do a CT scan, you find no abnormalities, the apparent abnormalities in the CT scan. When you do adrenal vein catheterization, they localize in one side and they get removed. And you have two patterns in those. One in which you have multiple APCCs, as you can see down here, or you have one in which the hyperplasia of the whole adrenal. Hiro Sasano, which is a great adrenal pathology from Sendai, doesn't like APCC. He calls it micronodules. And they sequenced these very micronodules, and they found different mutations in some of these patients. And this is the list that you cannot read, but some of them have multiple mutations within the same gland in different macronodules. Now, where do mutations come? Why so many? What are APCCs? And probably one of the crucial studies was done by Bill Rainey and Koshiro Nishimoto, that was a fellow with him, in which they look at adrenals from supposedly normal individuals, that's individuals that had donated the adrenals as a consequence of being donors, dying and being gracious enough to have in their will that they will donate the organs, and using those adrenals, in which the history was not entirely clear in most cases, because nobody is planning to die in an accident like that. They found many of them have fairly continuous, many have a few APCCs, and they sequenced some of those, and they found that approximately 30% of them already have mutations. The curious thing is none of them had mutations of KCNJ5. They have mutations of the calcium channel, or have mutation of the ATPase 1A1 or 2B3. So it's different. But these are normal individuals. If 30% of these unselected individuals have mutations, primary aldo is common, but it's not that common. So we don't understand what those mutations are, or if they are determinants that one of those mutations eventually leads to a tumor. We do not know that. So in a paper that's coming next month, in which we talked about disordered CYP11DB2 expression in primary aldo, we postulated that the wide variation in histopathological feature adenoma and the concurrent presence of APCCs raises the possibility that in most cases of unilateral production of aldosterone may actually represent bilateral asymmetric hyperplasia, with nodules frequently due to the development of somatic aldosterone-driving mutations. These mutations then contribute by some unclear mechanism to increased proliferation and muscle cells and the predominant site of aldosterone production. So whenever you take one adrenal out, if that's producing 90% of the aldosterone, obviously the patient improves, but it's not entirely cured. And we do not know what will happen 10, 20 years later on because they have not been studied. Of course, there must be patients that indeed have an adenoma and they don't have an abnormality in the opposite adrenal. But we are postulating that probably is due to asymmetric hyperplasia and asymmetric production of aldosterone. And that's the reason why we have so many problems with adrenal vein catheterization, that sometimes basal lateralizes, but when you give ACTH, it doesn't lateralize because we do it one way or we do it the other way. We don't recognize the patient that often. Well, something very disturbing that came from the Brigham. And they claim there's a continuum in renin-independent aldosterone in normal tendency. And they found that in 14% of normal tendency, they have a cohort that have been following, I forget for how long, 10 or 20 years, for a long time, that was started by Gordon Williams. And although you see in the two groups, the aldos were basically identical, and the aldo-renin ratio was basically identical. When you give them salt for 3 days and you collect the urine, you find that there is a group that corresponds to about 14% that cannot be suppressed, and a group that can be suppressed very nicely. I have a hard time digesting this. Actually, this gave me a little bit of indigestion, this kind of data, because it's hard for me to believe that 14% of normal individuals we have primary aldo. Whenever you study people with hypertension, the incidence is lower than that. So I find it hard. And probably one of the problems is this, and this study done a long time ago by one of the greats in endocrinology, John Lucher, that I met and became a friend of his, and he was already in late 80s when I met him, and he was really sharp. And what he had done in 1960, something that's hard to do nowadays, he measured secretory rates by giving treated aldosterone IV, collecting the urine and measuring the different metabolites and determine the percentage of different metabolites. He found that tetrahydroaldosterone was somewhere in his studies anywhere from 30 to 80%. What you have to reinterpret this because at that time we talk about tetrahydroaldosterone, there's multiple of them, but they have not been identified at the time. They were identified a little later on. Okay, but if you look at that, this is the aldosterone in the urine, which is an acid-labeled metabolite called 18-oxoglucuronide, and you see that in normal individuals, the percentages vary between 5 almost to 20%. Is this the explanation for those normal that perhaps they convert 20% of the aldosterone into the urine metabolite, or indeed they are producing more aldosterone that is hard to detect by plasma? I do not know, but something has to be clarified in the next few days. Now, some of the complications. The treatment overall is that you have an adenoma primarily, or you have a unilateral production of aldosterone. With all the defects of that, you remove that adrenal gland, and that's the preferred mode of treatment. If it's coming from both sides, you're going to treat it with a mineralocorticoreceptor antagonist like spironolactone or pleurenone, and the patient should do well. The long-term cardiovascular results with resolution of hypertension or cardiac hypertrophy are very similar. Okay, but the difference between using a mineralocorticoreceptor antagonist and adrenalectomy is just timing. You solve things with adrenalectomy fast, with mineralocorticoreceptor antagonist. By a year, you are similar. So it just takes longer period of time. However, as I said, not all might be what it seems. And this is a disturbing study that came from Taiwan. That's very, very recently, just a few weeks ago. And they did a study, and as you know, Taiwan has a sort of a national health system in which the 23 million individuals are in the insurance registry. And they have found from 1999 to 2007 that 2,367 patients with primary aldo were there, and they were studied. And they selected 754 aldosterone-induced adenoma that were identified that had either received adrenalectomy or they were treated with mineralocorticoreceptor antagonists. And what they found is that new onset diabetes mellitus after they have been treated, as you can see at the end, only 12.7 per 10,000 person years of patients that receive adrenalectomy develop new onset diabetes mellitus, but those treated with spironolactone was significantly greater. So obviously the result with respect to new onset diabetes mellitus was different between the two groups. Furthermore, they also studied in the fractures. And what they found, at least in women treated with mineralocorticoreceptor antagonists, the incidence of fractures was also greater to those women treated with adrenalectomy. So there seemed to be a difference. And how can you explain that difference? And there was a beautiful study done by the consortium, European consortium, in which Wittke Arl, which is at University of Birmingham in England, and the group from Munich, and a bunch of people throughout Germany, and I suspect, and also some from the United Kingdom. What they did is mass spectrometric-based analysis of 24-hour urine stereometabolome in 174 newly diagnosed patients with primary aldosteronism, adenomas and hyperplasias, compared with controls, healthy controls, and patients with incidentalomas, and patients with mild subclinical, and patients with clear-cut Cushing's. Okay, and the expression, and they look in the adrenal using my antibodies, or the expression of the 11-beta hydroxylase and aldosterone synthetase in 57 patients. They use a digital image analysis. That was done by this gentleman called Axel Walsh, which is in quantitative pathology and an institute down in Munich. And this is a sort of in bar way expressing both the normal subjects in white and the patient with primary aldosteronism. As you can see in tetrahydroaldo as a reflection of primary aldo, obviously it's very red to the end. And then the metabolites of the intermediates of the formation of aldo also tend to cluster to that area. Tetrahydro B not as much because it can come from the zona glomerulosa, zona fasciculata. But then the metabolites of cortisol also, they tended to cluster more at the high area overall, as you can see down here. And this is expressed a little bit more quantitative in this study. And as you can see, obviously tetrahydroaldo will be much higher in patient adenoma than controls. And cortisol in the urine tends to be also a little bit higher. Obviously in Cushing significantly higher. And total glucocortical metabolites also tend to be higher overall. Not in everybody, obviously, but overall tends to be higher, the same as androgen, adrenal androgen 11-beta-hydroxy, androstenedione. So they coined more recently a term called Cushing syndrome. So they combined the term of Cushing syndrome with Cushing syndrome into Cushing syndrome, basically saying that probably the explanation for the increased onset of new diabetes after comparing patients treated with adrenalectin versus mineralocorticoid receptor antagonists are due that when you take the adrenalectomy, there is abnormality in cortisol production in the adrenal, though it's subtle, but enough to have a clinical effect, versus the one that you have mineralocorticoid receptor antagonist in which you only selectively inhibit the mineralocorticoid pathway and not the glucocorticoid pathway. And that's the reason they coined. And I'm sure with time we are going to hear more about this, and this is going to help us. You know, it's a simple disease but too many questions. And I no longer know what the scope is of primary aldosteronism. And I like to quote somebody very infamous, William Rumsfeld. He was Secretary of the Department of Defense, and he said, "The known as we know, there are known knowns, there are things we know, we also know there are known unknowns. That is to say, we know there are some things we do not know, but there are also unknown unknowns, the ones we don't know, we don't know." I mean, it's and I think this is very appropriate to our field. There's things that we know, the things that we do not know, and the things we don't have the foggiest idea that exist. And I always want to thank all my collaborators, and this is a very short list. My wife and critic for the last 38 years or something, 39 years now. And my long-term technician, my current fellow, and then Bill Rainey and Kazunamba, who have helped me a lot. And my old friend Gianpaolo Rossi, which we always fight about what he thinks, and we never agree about things. And Francesco Fallo, which is so mild and so nice that you never disagree with him. And in Paris, Maria Cristina Zenaro, which is a brilliant scientist. And then in Munich, Martin Renke, who I spent 6 weeks with him this summer and had a great time. And Tracy William, which spent 6 months in Torino and 6 months in Munich. And she's probably one of the driving forces now in that Munich laboratory, because she is a driven person, very nice and very driven. And then many of my Japanese investigators, Hiroshi Sano and my old fellow, a former fellow Kenji Oki, which is a great guy. And thank you very much for this great honor.
Questions for Salto?
They can be irrelevant, doesn't matter. Yeah. Okay.
Thanks very much. That was fun. Is there any hope for a yet to be discovered aldosterone stimulating factor?
Great question. As you well know, there was a lot of excitement somewhere in the 70s. And we did some work, and it never worked in our hands, in which people have isolated aldosterone aldosterone stimulating factor that was supposed to be very high in patients with hyperplasia and low in patients with adenoma, and turned to be an artifact. It turned to be that they isolated chymotrypsin from the urine, and regular chymotrypsin can actually stimulate aldo. Anything that digests a member somehow can stimulate aldo. And there were several other substances that just never paid out. And we tried to study it, we never could find anything. There is the possibility, I think, especially the puzzling thing is, why do patients of obstructive sleep apnea have a 20% incidence of primary aldo? They all have hyperplasia. Is it something that whenever you produce a little hypoxia in your brain that you produce in excess and stimulate aldo? Is it the nerves that go into the adrenal that also contribute that? Or is the intermittent hypoxia that occurs every single night for many, many years that promotes mutations in both adrenals? We do not know. So I don't have a clear answer to you, but that is a possibility that cannot be completely ruled out.
Adenomas where the staining for B1 and B2 is heterogeneous.
Yeah.
When you say they're KCNJ5 mutations, do you know if the KCNJ5 mutations are in the cells that express B2?
That is
never 100%, right?
That's a great question, and unfortunately it was an era. The mutations were done before they had antibodies, before I gave it antibodies. So they got basically a good portion of the adrenal, they ground the adrenal, isolated the mRNA, and then they did the sequencing. Okay, and that probably is one of the reasons why Bill is finding significant number of mutation, because he is directing the sequencing to a specific area rather than take a big portion of the adrenal where we can miss things. Okay, it's the things, how things progress in reality. Yes.
Follow up on the mutational question.
Yeah.
I love the APCCs that Bill, our colleague Bill Rainey, has described. However, with so many APCCs in those autopsy specimens, one would have to posit that a second mutation is occurring to result, perhaps, in an adenoma in one of those clusters. But if I'm not mistaken, they haven't seen these adenomas with multiple mutations. 1. 2, what happens to those clusters as the cell differentiates into a fasciculata, which is the normal lifespan of an adrenocyte?
You know, unfortunately, humans are not mice in which we can do those kind of tracing studies. Okay? Because once you take one adrenal out, that's it. So it's not possible to know. There is a couple of cases, but you're talking about a case, for example, the Koshiro Nishimoto study when he was in Japan, in which you could see an APCC in which had the classical compact type cells, and in the border with the zona fasciculata, they have moved into cells that were clear type cells. It's a single case, so it's kind of hard if that frequently occurs or not, but that definitely raises the possibility. There's also a case that I collaborated with Koshiro, in which they did something that we don't normally do, in which it was a young patient that had severe hypertension, severe primary aldo, and they did bilateral adrenal bed catheterization, and they did segmental in multiple areas of adrenal. And they found the area in one of the adrenal, I can't remember left or right, in which in the bottom segment, the amount of aldo was significantly less than the rest of the segmental. And they had the guts to go and remove one adrenal completely and do a segmental. They removed the rest of the adrenal and they left that little segment. And then they did sequencing in multiple areas of both adrenal. They all had exactly the same KCNJ5 mutation. But toward the zona fasciculata, there was an area that the proportion of KCNJ5 wild type in the mutant was significantly less, suggesting that there were cells that had the 2 copies of the wild type, and also suggesting if both adrenal had the same mutation, had to occur very early in development. And That's very, very likely. And maybe it occurred after, they start at a certain point in which you already had two cell lines, in which only one undergo the mutation and they develop the primary aldo. But we don't know. As you know, it's very difficult to study humans in the sense that adrenals only come occasionally whenever you have. And bilateral adrenal hyperplasia will be very interesting to study, and they're studying them. The problem, you only have one adrenal. And unfortunately, I tried, but I didn't succeed yet. One of my old colleagues, again, one of Dr. Cohn's students from the old times, in the early 60s, when he went to University of Missouri, he had the hypothesis that many patients were producing too much aldo. And you couldn't control it with the drugs of the time, which some of you are old enough, like me, that we have a limitation of drugs. He removed both adrenals and the hypertension was improved. The joke when I went to Missouri was that the most common cause of adrenal crisis was that particular guy because he had taken a bunch of adrenals. If we could get those adrenals, it would be beautiful, but unfortunately they throw them away after 10 years, which is unfortunate.
So I have to ask you about something that apparently causes you indigestion.
Okay.
The study from Harvard, Gordon Williams.
Yeah.
I'm trying to put my mind around why that's controversial to think that there is a progression of a change so that there are people that don't have primary aldo, but they're in the middle and approaching it. It just seems, you don't wake up with primary aldo one day. It seems like there should be a continuum, and there should be people that don't quite regulate their aldo but don't have primary aldo.
Yes, I mean, that's a possibility, and there's a couple of studies. One was actually a study from the Framingham study, in which they categorized patients into quartiles. And they found the ones that had within the normal range but higher levels of aldo, if you follow for 10 years, they have a much higher incidence of hypertension than you were in the lower quartile. Okay? And recently, also, Anand from the Harvard group has published something similar also, that if you have the high level of aldo, if you follow them for 10 years, they develop hypertension. But do they develop primary aldo? I do not know. They call it that subclinical primary aldo. Of course, you don't go from 0 to 100. You go slowly, and we don't catch them early. So if we study a large population and we don't treat them and we wait another 10 years to see, maybe we'll see that enormous develop. But we know we are not going to do that. We just can't do that.
Other questions? All right, well, we're going to have plenty of time for questions here at the break.
Yes.
Join me one more time, and thank you, Celso, for visiting.
And the two Ed Schteingart colleagues that were in the picture were our own Ralph Knopf and the good Sumer Peck.